Hello, everyone. Welcome to the webinar on Choosing Wisely implementation across Georgia. Before we start, here are a couple housekeeping items. You can download the slides from the handouts pane. We encourage everyone to participate in the conversation by typing your comments and questions in the chat box. And please note that you will be muted until the Q&A sessions toward the end of the webinar. And if you wish to speak, please click the hand button to raise your hand, and you will be unmuted when it is time for questions. You can also adjust the size of your slide view by clicking and moving the three lines between the speaker panel and the slideshow. And after the webinar, we'll send you the recording of the webinar, and we'll post the slides for download at the PCPCC website. And last but not least, please take the post-webinar survey. Your feedback will be greatly appreciated. About PCPCC, PCPCC, or Patient-Centered Primary Care Collaborative, aims to advance an effective and efficient healthcare system built on a strong foundation of primary care and the patient-centered medical home. Our mission is to promote collaborative approaches to improve primary care. We promote the chair principle of care, which represents all aspects of primary care, and we focus on the concept of patient-centered care through patient-family engagement and patient activation, which will help reach the goals of improved cost, quality, and experience outcome. And through the Transforming Clinical Practice initiative, PCPCC Support and Alignment Network strives to improve patient and family, clinician, and community strategies for engagement. We are working with our key partners to provide valuable education programs and technical assistance tools to help practice meet their needs. And to learn more about how we can help your practice, please visit pcpcc.org/TCPI. And now I would like to turn to my colleague, Kelly Rand, for today's webinar.
Thank you, Tanya. Welcome today. We're excited to provide a really interesting case example of Choosing Wisely implementation. Today, we're hoping that you'll gain an understanding of some of the best practices and also learn about the barriers to regional implementation, learn about some specific tactics that can be used for Choosing Wisely implementation, and really think about how change management strategy needs to be implemented. Next slide, please. Our speaker today will be Scott Pugel. He's the Physician Program Director of Resource Stewardship at Kaiser Permanente, Georgia. He's also a practicing physician, board certified in pediatrics. He graduated from Creighton University School of Medicine and has been in practice for more than 30 years. As I have been through this Choosing Wisely series, will be moderating the session. Next slide. Just to connect this directly to TCPI and the engagement metrics that you're working on, through our series, we've worked really intensely in thinking about how to engage the patient directly at the point of care and thinking about how you can use them in implementation. Today, we're going to take a little wider spectrum view and look at how patients are engaged through the lens of stakeholder engagement, including marketing as an insurer. We'll include some of the point of care conversations, talking about tools that could be used, but really talking about a communications and marketing plan overall, as well as how that integrates into a change management strategy and implementation in general. As always, the basis of choosing wisely and encouraging conversations with clinicians and patients is founded in the idea of patient activation. So we always hope that it's really deeply embedded in this engagement idea. Next slide. And now I'd like to turn it over to our speaker, Dr. Puja.
All right. Good afternoon or morning, depending where you are. I'm Scott Pugel, and I'm a pediatrician and head of resource stewardship in Kaiser, Georgia. Just want to let you a little background. Our region has about 300,000 members with about 25 medical offices. We focused on adult primary care, which was around 170 physicians at those offices. And we are a staff modeled salary physicians. Next slide. So in my resource stewardship work, one of the things that we stressed was practice variation. And so we had a hypothetical image of what we thought our practitioners were doing. And so this is kind of a graph of what we thought we would see. Next slide. And so we were looking at, when you look at what impedes best practices, there are several different areas. The guidelines themselves, motivation of the professionals, the patient's knowledge, the culture of your group, and then looking at the different support and barriers and policies that you have within your group. Next slide. So what we did early on as I started resource stewardship projects in the Georgia region, we hit on choosing wisely, and we thought that this would be one of the best projects to start our practitioners to use because it had been developed by the different boards of medicine and had a lot of credibility in that respect. So we wanted to increase our use of best evidence of care and stress value in the care we delivered, as well as promoting good discussions in the exam room and among ourselves, discussions on practice variation among the different practitioners. Next slide. So we approached this in a change management aspect, and I had quite a few people in my group. And so we had communication planning where we developed a strategy, identified who we needed to reach. And then we had a report development, developing those reports, how we were going to approve those reports and roll them out. And then we did a training and education for the people that were going to implement our changes. Turn to the next slide. So we knew there were going to be a lot of issues and risks, and one of it was going to be time for provider involvement. Practitioners don't have a lot of time. It might cause a disruption in the workflow. We needed to build consensus of the guidelines. And then we had limitations on the reporting. We only had so much analyst help to be able to work on these reports. We knew that, or we were concerned that there was going to be a lot of member dissatisfaction, possibly provider dissatisfaction and staff satisfaction. So we knew we were going to have to concentrate on those areas. Next slide. So for our communication plan, we did kind of an internal and external plan. And basically, we wanted to internally let everybody know about what we were going to be doing. The reports we were going to be giving out were for information only. There was no punitive measures for it. and we are rest assured we wanted people to be very satisfied with what we were doing. We also, externally, we wanted to continue to have high patient member satisfaction. We also wanted to actually try to push Choosing Wisely in the Metro Atlanta area publicly. And kind of an aside, we actually got the Medical Association of Georgia to adopt a resolution supporting the ABIM's initiative supporting Choosing Wisely. We couldn't get a direct, we couldn't get them to support Choosing Wisely outright, but we got a little bit going on. So next slide. So we have a structure of leadership where we went to the top leaders and then to the chiefs and to the practitioners. And then we also had communication around our members, which are our patients. We also reached out to some of our employers about what we were doing, and some of our work was in marketing materials to potential employers and members. Okay, next slide. So one of the keys to our project was the report development. And we actually went to our chief of primary care with the different Choosing Wisely initiatives that had been identified. And he picked 4 of them that he thought would be good opportunities for us. And so we then created those reports and vetted them. And we spent a lot of time making sure that the reports were done accurately. And these were all unblinded reports, and we had them to be able to be drilled down to the medical record number so that the practitioners could actually look at their report and see the actual details. This allowed us to have feedback that if there were errors in our reports, and I'm happy to say that we only had 1 practitioner reach out with an error that it was a simple one that we quickly fixed. So we had spent a lot of time making sure that the reports were accurate. And then we did a targeted rollout. We kind of divided up the region into 4 groups. That was something, in hindsight, we really didn't need to do. We could have rolled out all 4 initiatives at the same time. Really didn't make a difference. And these reports were automated so we have an electronic medical record. We couldn't do this without an electronic medical record. And we had the reports built to automatically be sent out the first day of the month, every month, to the providers. Next slide. So these are the things that we picked. The Choosing Wisely on DEXA screens on women under 65 and men under 70. The CBC being done as a routine screening test. And we selected CBCs done at a physical exam that were coded either as screening or coded as with a well exam. And so we use that as our criteria for routine screening. Annual EKGs done on low risk patients. Again, we used the physical exam and looked at that group. And then not imaging for uncomplicated headaches. Next slide. So this is a sample of a report that we sent out, and this would have been sent to 1 medical office. And you can see the data lines are monthly. The physicians, of course, I've removed their names here, but their actual names were here listed, and it would show their data, and they could click on their name and see their specific data per MRN. And you can see, for example, in this office, the significant variation of getting an EKG at a physical. We had one practitioner who 5% of the time ordered an EKG, and one practitioner 95% of the time ordering an EKG. So there was wide variation, and these two practitioners worked right next to each other. So I think the nurses knew who was ordering the most, but I'm not sure the practitioners knew that one was getting so many more than the other. And you can see that as the practitioners saw their report, you can see the general change over time. And the one practitioner who was an outlier, he improved a lot. He still was the highest member of the group, but significant change from baseline. All right, next slide. So some of the training and education that we did, we actually created this poster that we put in the exam room that kind of set expectations for the patient on what they should talk to the doctor about, what tests or screenings do they need, what vaccines do they need, and other tests that might be ordered if they had symptoms or risks. And this was a good education, and this way, when the practitioner was talking to them about, whether they needed the EKG, they could even refer to the wall chart for the patient. The idea was to provide that tool for the practitioners, and a lot of patients would read this information before the practitioner even went into the exam room. We wanted to make sure that we had good patient satisfaction and clinician satisfaction and reduce a lot of the patient anxiety. So next slide. And then we also provided the practitioners with some handouts, specifically the Choosing Wisely materials, that we gave them hyperlinks that they could put into their after visit summary for the patients. They could also have pre-printed handouts and that they could hand the patient with this information. And this was used by a lot of practitioners when they would have those initial conversations. Next slide. So in our project, this shows kind of a timeline, and this is the CBC ordered by month. And if you look at the November of 2013, that's when we kind of introduced the concept of choosing wisely at a business meeting with our medical executive, saying that we were going to embrace choosing wisely, and that in the future we were going to be running projects on that. And you can see that mention actually created some change. So when we went back to baseline data, we saw several practitioners change their practices based on the fact that in the future there was going to be a report on it. So we thought that was very interesting. And then we started doing our development in early 2014, and we had the first reports out in May of 2014. And then we saw significant changes from June and July. Sorry, I have a cold. Next slide. So this shows our choosing wisely data for the CBC. And you can see the significant change from 2013 baseline till when we ended the project in 2015. And so the results were astounding. They were better than what we expected. We continued to monitor this, and you can see in 2016 we stopped sending reports, and so there was a trend up. We are currently still running these reports yearly and sending them out to adult primary care. What we find is, as we've hired new practitioners, they are often the ones that are routinely ordering like a CBC at a physical. So next slide. So this is our whoops, back one slide. This was our ordering annual EKG slides, and this one was even more significant reduction in unnecessary EKGs that pretty much sustained itself afterwards. Next slide. So our results, when we looked at baseline of 2013 to 2015, we at CBCs at a physical declined from 42.5% to 3.1%. The EKGs at a physical declined from 14.9% to 0.6%. Our DEXA scans, inappropriate DEXA scans, declined from 11.8% to 2.5%. And imaging of uncomplicated headaches declined from 6.5 to 3.4%. So, in a year, we did 26,000 fewer CBCs, 65,000 fewer EKGs, 800 fewer DEXA scans, and 60 unwarranted CT scans. And when we went back to look at this, these were actual CBCs and EKGs and DEXAs not ordered, not that there was any coding changes. So, for example, if you did a CBC and you coded it for associated with anemia, that wouldn't count. That wouldn't show in our data. So conceivably, people could have looked better on the reports by maybe doing some coding that was a little iffy. That didn't happen. So these were actual reduced, wasted tests. Next slide. So some of this was received very well by our different offices and teams, and some of the teams really got into it. They would have meetings about how they were doing, and one of our teams decided that they wanted to do another Choosing Wisely subject too. So they wanted to do one on PSA. So they kind of embraced the Choosing Wisely philosophy and decided they wanted more initiatives to work on. Next slide. And really the tips for success was, it started from the top. When we had from the top of the organization that we were going to work on this, pay attention to it, and driven down to the front lines. And from the front lines up, we brought the frontline practitioners into our discussions on how we were going to do this. So really getting everybody involved. And it we had to realize that we prepared everybody for the possibility of dissatisfaction, and we didn't really get that much. We actually even talked to our people that answer member complaints on the phone, and we prepared them because we thought that we were going to have patients upset about this, but we didn't really have reaction like we were expecting. So that was really good. Next slide. And this is a picture of Carl Zaboka. He was our chief of ambulatory medicine who really helped us with this initiative. And he tells the story of a patient who came in and, you know, wanted to have his yearly EKG. I think it was maybe his yearly EKG or his CBC. And Carl talked to him about choosing wisely in the initiative, told him about Consumer Reports and choosing wisely. And the patient went back home, looked all up this information, and sent him a note thanking him and very impressed of what work we were doing. Next slide. I think that's my last slide.
Okay. So yes, we encourage everyone to participate in the conversation by typing your question and comments in the chat box. I think we have a couple questions. Marilyn, is it right?
Yeah, there were a couple of questions so far. One from Susan Dade. It's like, where did you get the detailed measure specifications from?
So we took the spirit of the Choosing Wisely initiative and kind of looked at what they were measuring, and then we tweaked the information so that we would make sure that we wouldn't have any false data where providers would say, well, this was really justified. So that we actually made sure that what we were giving them was true cases where something wasn't indicated. And so we made sure that our data was going to be as accurate as possible to meet the spirit of the Choosing Wisely initiative.
And Scott, how long did that take? I know a lot of people we talk to when they're working on Choosing Wisely, the data part is always a question of when is it going to be good enough to share? Right. So that was the whole reason. I mean, it took us, when we would start one initiative, we got a coder involved. We would get all the codes. We'd review them. We'd go over with the chief. I mean, it would take at least a month probably to get one report done, to be able to be sent out. And we actually did several, because we did this in adult primary care. We also did this in many specialties also. But the data today, I'm just presenting from adult. We came across a lot of things when we ran the reports. We were doing, two things happened. Either we were doing such a good job, there was no point in that initiative, or or it was too complex. We could not get clean data, and so we didn't want to be sending out reports where people would be saying, well, this isn't right. So we didn't do that initiative. Interesting. Thank you. Marilyn, are there other questions? Or I also have some more if there's not.
Yeah, there are a couple more questions. One, it's a fairly quick question. Is the exam list proprietary? And if it's not, this is Teresa Lane, wanted to know if we could get a copy.
No, it's not proprietary. We kind of made it up with the adult medicine chiefs. So, and we put Choosing Wisely on it and our name. So.
Okay. Next question was from Richard Chunk. Did you make any changes other than giving reports and providing handouts and education? Were there any financial incentives or other specific interventions?
No, there were no financial incentives. It was the, I mean, you know, I think what drove this the most was the fact that there was we did do a CME on it with the Department of Medicine about a physical exam and what they should do. And then when you did the CME and you combined it with the unblinded reports where everyone saw what they were doing and then saw it monthly, that really drove the change because everybody's wanted to look good on the reports. Some people took a little longer to do that, but almost everybody did.
When talking about taking longer, from the implementation that we've seen happen, we've seen that things like maybe cutting out daily CBC goes pretty quickly because nobody wants to review a daily, or even in general, I guess yours was the annual CBC. Things like those types of blood tests sometimes are easier to de-implement than something like headaches, imaging for headaches. So did you see any difference between the areas that you specialized in, or did they all sort of progress in the same speed?
I think the lab ordering was pretty quick, and the EKGs were really quick too. And it was more when we were doing this, we were also, when you think about, patients were used to possibly letting their doctor know, hey, I'm coming in for my physical next week, can I get my blood work done? And so practitioners were now, well, no, you know what, we're going to discuss and see what you need at your exam. So that was the big change for some of our patients that we were concerned with. Most patients understood, but that was a change for practitioners. So the interesting thing was that when I looked at other lab tests, they declined too. So the amount of liver function panels done. There were some of our practitioners had, like, in their EMR built their preference list, and they would just blow those orders in at a physical, not even thinking about it. Well, because of this work, they now started to think about it, and so they started like, oh, okay, I don't really need that. And some of them changed their preference list too.
That's great. Sorry, Marilyn, I didn't mean to interrupt your
no
group question.
Oh, no problem. We have another question, but it doesn't seem like I can get it to fully scroll down. It's like I'm having a little, oh, wait a minute. They wanted to know how are unwarranted services measured from the reduction variance, and how do we know that the average that results from this, how do we know that the average that results from the reduced variation is the appropriate number of services? Was there an optimal level? Was there an optimum level for ordering these tests?
Right. So no, we had no idea when we started this what we didn't set any targets or anything because we don't know. And so for some of the criteria, like for the DEXA scans, you could say because that was a measure on an inappropriate DEXA scan. So if you ordered it in somebody who's too young, that would be, so that one you could have said, well, we should really try to get to 0. But the headache one, that's a very difficult one because there are patients that need those scans. And so we didn't want to push anything to where there was going to be a quality issue to 0. But when it was screenings, the screening CBC, if it was warranted, it should have been coded for a reason. And so when we went back and looked, the number of CBCs done for an appropriate reason stayed about the same, and the drop was just all in those that were coded for a well check or for screening.
And just to follow up on that, from our standpoint, when we're recommending what people do when they're implementing, one of the reasons we call it the 40% rule is that if you have something that's 40% or more of a test that's been identified as something that could be low value care, you have a lot of room to improve. So we often suggest starting there, because you very definitely should probably not be doing 40% or more. And then when you start to move at, KP's an excellent healthcare center, they're in the lower numbers. Sometimes when you're in a lower number and you want to address that issue, we suggest putting in balancing measures to look at patient safety issues so that you can find where your right baseline is. There are no absolutes or thresholds yet on de-implementation, but there are things that you can think about, that what would be the consequences if you were under testing, and measure those along with the volume reductions as a general rule. Marilyn, do we have more questions from the audience?
Yes, we do. There's, I think, like 2 more. Was there a way of determining if a test was not ordered, but it should have been?
No, because that would require chart review, which was beyond our EMR.
Okay, and going back to the detailed measure specifications, they were wondering if you developed your own measure definitions, and were there any exclusions, and if so, how were those decided?
Well, I think we took the spirit of choosing wisely and looked at what the recommendation was. So, for example, the CBC, a routine CBC shouldn't be done as a screening test. So we decided, well, we'll isolate when that may occur, and we figured it was going to be physical exams. And then we would say that any CBC ordered coded to a physical exam or coded to screening was considered a routine screening test by definition. If the CBC was coded to anemia or coded to fatigue, that was considered a legitimate CBC. So that's how we kind of set the baseline. And when we ever had anything that was kind of iffy, we would always err on the side of excluding it. If we really tried not to have any cases of practitioners saying, well, I don't believe this data, this isn't right. So it's only as good as their coding. So it's true, maybe somebody needed a CBC for a medical condition, but if you coded it for screening, but you really wanted to code it for fatigue, then you're correct that the CBC was justified, but you didn't code it that way.
Okay. Next question. Are you now incented to evolve choosing wisely into areas such as protocol for chronic diabetic care, disease reversal? Let's see, I'm sorry. Or other chronic conditions?
So we look at the choosing wisely, the different choosing wisely criteria when we find like there's seems to be some added ones all the time, and we're always working with the chiefs of each specialty to identify areas that they may want to do. We have gone off sometimes under the choosing wisely nomenclature to create our own. And so, for example, in pediatrics, we did one around lipid testing and appropriate lipid testing. So sometimes we have pediatric patients who get their cholesterol done, and then next year they get their cholesterol done, and then next year they get their cholesterol done, and it's normal every time. So we said, well, let's create our own Choosing Wisely one that you don't need to repeat a normal cholesterol in a pediatric patient. So.
We love when people do that, FYI.
And I have another question. Did coding improve or change?
So we didn't find any erroneous coding. So we monitored to make sure people weren't coding to avoid a measure. I can't speak to whether our coding accuracy was better. My gestalt is that practitioners got a little bit more specific in their coding, where sometimes they might just associate everything they did with well check. Now they were like, oh, no, the CBC, I'm getting that because of fatigue.
I don't have any other questions.
Okay, well, I have a couple more, but I wanted to prioritize the audiences.
Kelly,
yeah.
We have one person raise her hand for questions.
Oh, great.
So Deborah Southworth, you are on mute. You may ask your question. Okay. Okay. Deborah? All right. Deborah, please feel free to type your question if you would like to ask the question. And Kelly, please take it away.
Sure. So you mentioned a little bit about how you worked with employers, and you have quite a robust communications plan. Did the employers also do any messaging about choosing wisely that you know of to their employees?
Not that I know of. I think the message to employers are looking for their members to have cost-effective care, and I think it was an example of some of the cost-effective care we were doing for their employees, so that we were paying attention to ordering the right tests at the right time, and not over ordering. So I think that's how it was delivered to the employers.
Okay, great. So
and I do have another question.
Oh, sure.
Oh,
Sub-in,
sorry.
Audience always gets preference.
Oh, the other question was, this is a follow-up to the coding. Was there more coding for symptoms such as fatigue, and did this adversely affect the health insurance reimbursement for the patient? Did the patient on record for a condition that might not have panned out?
So when I looked at specific coding for the CBC, for example, the CBCs, we tracked how many CBCs were done at a physical and how many were coded for an excluded condition. And when we tracked it, it really didn't change. So the numbers didn't greatly accelerate. And so that was one of the things where I was concerned that possibly, in other words, our providers were doing a pretty good job. They were coding acute conditions for the CBC, and everything else was actually screening. They would often just code it to a well check. They wouldn't even check screening. But we didn't have, like, we didn't see now a whole bunch more fatigue codes dropping at physicals.
So to talk, data and feedback is a great QI technique, but I think we've all also seen points where the clinicians who get it don't trust it. Now, you certainly worked to be very accurate, but is this a process that you had already used in other things, so you had sort of a built trust already, or were there things that you did that you think, other than just real accuracy, that helped the clinicians who are getting these reports trust in the data that you were providing them?
So I think the accuracy was critical, because there had been sometimes reports out there, not by me, and my part in New York, but other areas that were kind of like, oh, iffy, and people didn't believe reports. So that was critical, and we got the trust built there. The other thing was that these were all unblinded, so everybody saw everybody's data, and that was, in some places might have been considered radical, but in our organization, we have already had unblinded reports specifically on patient satisfaction. So every practitioner sees how everybody is doing on their patient satisfaction scores. So there wasn't a big shock now to see how you were doing on some clinical scores.
When you started the patient satisfaction scores, did you sort of graduate into unblinded, or did you just start with unblinded there too?
So we've been doing it so long, I can't remember, but we've been doing it unblinded for at least 10 or 15 years.
Okay. So a deep culture in the unblinded. Great.
Yeah.
I think that was all the questions I had. Marilyn, any other questions that came in?
No other questions.
Great, then I guess thank you so much, Dr. Pugel. And Tanya, I know you have some wrap-up webinar discussion points as well.
All right. Yeah, thank you, everyone. And also thank you, Kelly, Dr. Pugel, and also Marilyn, for facilitating this webinar. So I just would like to encourage everyone to connect with PCPCC through our social media, the information by going to the information on the slide. And again, we do offer a wide variety of resources that we can help your practice. So please visit our website at pcpcc.org/TCPI. And yeah, I would like to thank everyone again for participating in this webinar. And please take the post-webinar survey. Your feedback will be greatly appreciated. And we'll send out the recording, and the slides will be ready for download tomorrow. And yes, please feel free to reach out to us if you have any questions. Our contact information is on the slide, and I hope everyone have a good day. Thanks again.
Thank you.
Thank you.
Thank you.